Okay, we're going to get started now, Simon. I want to welcome everyone from our international audience, especially our young neurosurgeons, to this Foundation for International Education Neurological Surgery Virtual Visiting Professor. This is a web-based teaching tool which we're using to unite our fellows and all neurosurgeons, particularly young neurosurgeons worldwide, into a common curriculum of themes. These are recorded and will be available on our website. They last an hour as a Webinex. But we will also have opportunity to answer questions which are not covered. So if you put those in the chat, that'll be important. Our format is that one of our young neurosurgeons, often one of our graduating fellows, in this case, Dr. Simon Makula, is going to be able to be our moderator, and he will introduce our distinguished visiting professor, who today is Dr. Andres Rubiano. And this is very important because his expertise is in trauma, and his insights into international and global neurosurgery and the interaction with trauma is going to be essential for all of our careers. So with that introduction, I'd like to thank you all for participating. It's so great to have you. And we'll give the floor to Simon, who will introduce our guest.
Thank you very much, Dr. Dempsey. Thank you for the opportunity to moderate this webinar today. Dr. Dempsey, I also must say thank you for your groundbreaking initiative in enabling the FIENS Visiting Professor webinar sessions. The introduction of these webinars has not only bridged geographical gaps, but has also created an invaluable space for knowledge sharing and professional development within the neurosurgical community. The impact of these webinars extends beyond the virtual realm, empowering neurosurgeons, residents, and medical professionals worldwide with a unique opportunity to engage with leading experts, to stay abreast of the latest advancements, and foster a collaborative spirit in our shared mission to enhance patient care. My name is Simon Mukuye. I am a 2019 FIENS Clark Family Scholarship recipient, and thanks to the award, I managed to complete my neurosurgery residency training in 2022. From the time I completed my residency, I've been working in Uganda at 2 university teaching hospitals, both located in rural Western Uganda, namely Kampala International University and Mbarara Regional Referral Hospital. The vast majority of treatments offered by the neurosurgical services at both these hospitals is neurotrauma care. And I think that's why even today, it's still a very relevant topic for us in this region. And the topic for today is current and future trends of neurotrauma management in a global context. And the speaker is none other than Dr. Andre Rubiano, who is a world-renowned neurosurgeon and neurotrauma specialist from Colombia. He is a professor of neurosciences and neurosurgery at El Bosch University, Bogota, Colombia, and a medical and research director of the Meditech Foundation in Cali, Colombia. Dr. Rubiano acts as co-director of the Global Neurosurgery International Fellowship Program from Meditech Foundation, Colombia, Cambridge University, UK, and the Barrow Neurological Institute at Phoenix Children's Hospital in the USA. He is chair of the Neurological Surgery Service in Valle Salud, clinical network in Cali, Colombia, and a neurosurgery professor at Universidad del Valle in Cali, Colombia, and is a recognized leader in neurotrauma and global neurosurgery. Finally, Dr. Rubiano is the chair of the International Committee of the AANS/CNS Neurotrauma and Critical Care Joint Section and co-chair of the Neurotraumatology Committee of the WFNS. Dr. Rubiano, you are very welcome to start your presentation.
Thank you so much, Dr. Simon, and also thank you to Professor Dempsey for this great opportunity, and to FIENS team. I think this is a very privileged opportunity to share some of what we are doing in this specific topic. Just go over Sharing the slides. Perfect. Thank you so much. Okay. So I'm going to speak about current and future trends of neurotrauma management from the global perspective in a global context. And as has been mentioned, there are several partners that have been working with us in many of these specific topics. There is no conflict of interest for giving this talk, and this is all part of what we have been developed in conjunction with the Global Health Research Group in Neurotrauma, and now with the Global Health Research Group on Acquired Brain and Spine Injuries, where we are working with several partners, especially from Africa, Southeast Asia, and Latin America, integrated and supported by the University of Cambridge and an NIHR grant specifically on this topic. So I'm going to propose three objectives for the lecture today. The first one will be to discuss fundamental aspects of neurotrauma in the framework of the different impact that is mentioned at global level, also the pathophysiological aspects. The second one will be to discuss present trends in the process of diagnosis and decision making for the management of TBI based on scientific evidence and expert consensus. And the third one will be how to share the transitions from the present to future trends in personalized and precision approaches that will impact outcome of TBI patients within the concept of organized care systems. So for the first objective, that it will be the fundamental aspects in the framework of my global health impact and the pathophysiological aspects. I want to get into some basics from the epidemiological perspective and also from the science behind the neurotrauma pathophysiology. Just want to share these two nice pictures related the famous surgical procedures. One from the El Bosco in the Museo del Prado in Spain, the famous extracting the stone of the madness. And the second one is a lithograph about the refining in ancient Peru from Robert Town in Australia. So it's just to illustrate how, as has been mentioned by Simon, trauma has been considered a critical aspect in the management of patients for centuries, and we are now understanding a little bit the impact of this process worldwide. So related to the epidemiology of the condition and also the global burden of the disease per se, we are just starting to integrate many of the data that have been driven the analysis from different regions of the world. We have the periodical discussion of the global burden of disease study from the WHO and many other collaborators where we have identified the impact transversally in many countries in the world. And also from the work that we have been doing with the group of the University of Harvard, from the global surgery and social change, it has been estimated that most of the data that is coming to understand the condition is regularly driven by the motor vehicle collisions data. And we have lack of data regarding other types of injury. But it is pretty common that if we overlap many of these maps of the impact of the disease with the human developing index map, we understand that there are areas that does not have a lot of resources, but definitely have a lot of patients. And it's really interesting how you interact with these conditions when you talk about prevention. That is a very critical point in order to tackle the disease. Because it's really related to a lot of aspects, including education level, and all the social disparities that regularly have been present in many of these analyses from United Nations. So we understand that as less human development index have a region, more conditions associated to be exposed to trauma, and in this case, to neurotrauma. So this is something that we always need to take into account. These graphics are very explicit related to the impact of the condition. These are from the Global Burden of Disease Analysis 2019. And if we took all the global data for both sexes, for all ages, we can see the smallest screen, green screen in the corner, and we can say, okay, there is not too much impact trauma related to other conditions like the chronic diseases that are in blue, all the infectious diseases that are in pink. But when you go analyzing on specific groups, you can understand how much is the impact for the condition. The second superior screen is related to the group from 5 to 14 years old, and you can see how that change, and that one is for high developed areas. So this is not only a condition that affects the less developed areas, but also affects the more developed areas. And for the other three graphs in the bottom of the slide, we have the analysis for the same population in high income, high middle income settings. Is still a lot. For the 15 to 49 population in low middle income settings, and for the 5 to 14 years old in very low income settings. So it's very transversal, but it's also interesting when you go regional, you can understand how that impact is in a specific regions. This is, for example, the analysis for Latin America compared with other neurological and neurosurgical conditions. You see the first graph related to all ages, and the trauma per se is bigger than the group of brain cancer, degenerative conditions, congenital conditions, and stroke. But if you go over these specific age groups, like, for example, the other is related for 5 to 14 years old, you see the high impact in this specific population. And when you go over the 15 to 49 years old, you can see the high impact related to other. This only decrease in patients that have more than 70 years old, where stroke comes over all these topics. So this can allow us to identify the magnitude of the problem. And as Simon mentioned, for example, in his hospitals, in some of the hospitals that he practiced in Uganda, is the most common cause of management neurosurgical patients. So neurotrauma definitely is a global problem. It's a global disease, impact very young and economically active population. And we need to start going into the concept of low resourced areas. We mentioned that, and the concept specified that areas where the health system does not meet standardized criteria that are defined by multilateral organizations in terms of infrastructure, human resources, or technology. So are areas where quality of care and best practices are not always present due to the lack of these conditions. So when we speak about managing patients in these low resource settings, there are so many aspects that need to be tackled if you want to improve that, even for geographic and environmental conditions, financial shortage, paucity of knowledge, underdeveloped infrastructure, restricted social resources, influence of different beliefs and practices, human resources limitations, suboptimal healthcare delivery, and research challenge and other considerations. So there are so many factors that affect transversally these aspects in these regions. But it's so interesting also to see, as we mentioned before, this is not only considered for very low middle income countries. This is a study that we published some years ago, analyzing the disparity on traumatic brain injury outcomes in North America, and especially in States, where we found that rural areas have poorer outcomes compared with main metropolitan cities. And you can see in the small graphs how the trend, if you are more rural, the mortality increase. If you are more rural, inclusive all different causes like unintentional injuries, violence, and all other causes of including motor accidents, definitely have bigger mortality in more rural areas. So we need to take that into account when we mention these aspects. I think related to the aims of the foundation and also to the aims of many of the organizations that we work for, sometimes we forget the important roles of the neurosurgeon as a pivotal point for organization of the trauma care systems. This was highlighted in the 80s and 90s by Dr. Lawrence Pitts, who was chairman of the joint section of neurotrauma of the WNSCNS for some years. And he started publishing a lot about this concept of how to integrate the neurotrauma to the regular concept of trauma systems and how the neurosurgeon play a fundamental role in the development. Many of these talks from Dr. Pitts were originally some of the basis for developing projects like the Brain Trauma Foundation guidelines, including many of the standards and recommendations for specifically talking about trauma systems implementation that we bring many years after in some articles related also to this topic, considering the concept of strengthening neurotrauma care based on many other concepts that were developed at that time, especially at the WHO within the trauma community by Dr. Charles Mock, who was a champion of the quality improvement process in trauma care in general. So we were very lucky to interact with him many times in order to bring a little bit more some of these concepts to the neurotrauma care area. So based on many of these fundamental concepts, now we have evolved to the concepts of quality of care and also guided therapies in trauma and in neurotrauma. We understand that there are best practices, recommendations, and also many booklets that recommend how to improve resources for the care of the injury patient. We have some guidelines from WHO related to trauma quality improvement. And we have a specific topic guidelines for management this condition. We have several guidelines worldwide. We have some of them that are more recognized than other ones. There are variations in regions, but definitely all are talking the same, is how to improve care of these patients. It is very important to understand when we talk about roles of the different specialists, and also in this case, neurosurgeons, that the performance of providers for working within organized care systems is totally different if you are in an area that does not have organized care. So understanding the context in which you manage your patient is crucial, but we understand that there are so many factors that affect that performance either positively or negatively because of the conditions. And returning to the slides previously where we talk about low resources settings, there are definitely many issues in low resources settings that affects the performance of the regular physician working in these areas. So this means that even if you are a neurotrauma practitioner, but you are someone that is not fully dedicated to the topic, you do not follow the guidelines or even do not generate interaction with those technical documents, guidelines, protocols, in the same way that a person that is more dedicated to this type of management in order to have correlation between the practice and the outcome of the patient. We have been working with a group of experts in the field of trauma science in order to bring to an end this review that has been a very painful process because of the difficult requirements to obtain the data from most of the studies that is related to organized trauma systems and designated trauma centers for improving outcomes of injured patients. But definitely what we have seen during this process is that the subspecialized physicians generate a context of knowledge with high levels of skills and experience through the management of significant volume of patients, but especially in places where academia, research, and the concentration of resources and equipment led to better decision-making and multidisciplinary integration with other specialties. So this means that even if you are in any region of the world and you have loads of patients from a specific disease or condition, you need to have some sort of organization of care within an academic background in order to use better those resources and really affect the outcome of the patient. It has been many years evaluated by the American College of Surgeons in the Trauma Center Designation Program and has been described in the American literature several times regarding the outcomes of the specialized centers versus the non-specialized centers. So moving from all these general aspects of the system, let's go over the specific pathophysiological issues that needs to be understood in the actual moment of the process of care. So now we understand that global neurotrauma is a challenge condition. There are so many aspects that are not related to the care per se, but to the environment or the context of care that depends a lot of resources, depends of the level of knowledge, and also depends of how we organize that care. And also now we understand that in any area of the world, you will perform better if you dedicate more of your time to understand better the specific condition that you are managing. And this applies for any other different pathology, but also applies for neurotrauma. So if we go over the roots over the physiological and pathological concepts of neurotrauma, we have facing very classical and traditional schemes of understanding TBI. From many years, two concepts that we have very clear: the primary injury, that is the damage to the bone vessels and neural tissue because of the external mechanical force, and the secondary injury, that is the process after the primary injury that include physiological alteration, especially inflammatory, neurochemical, metabolic tissue, are the conditions that we need to face off when we have this type of patients. But many of these concepts have an evolutional process from the very initial models that were described. We understand that many of these concepts like ICP, CBF, cerebral metabolism, and others come from many European labs in the 60s and 50s. And we still manage some of these concepts as a base knowledge from this condition. But we also need to understand that many of these concepts have evolved over the time. And now we are in an era that we can understand deeper concepts from the proteomical aspect. We talk about neuroproteomics in neurotrauma with many of the different proteins that we can evaluate, understanding what is happening specifically in many regions of the brain. And we move to the neurodegradomics with specific biomarkers that can be associated with some of the main secondary injury aspects that we mentioned before. And now we are in the era where we are trying to find correlation between many of these biomarkers on every different level or category of the disease, and also correlated with each one of those stages that are associated to the secondary injuries. That at some point even have been proposed that we need to move for further concepts like the tertiary injury pattern, because involving many of these new knowledge and concepts into the secondary injury can be sometimes too much to be clear understood. So we need to maybe evolve over many of these concepts that we have been for years. Another topic is related to the neuroimaging analysis. We know that CT is the basis for decision making in many of these patients, if CT is available, because we understand that CT is not widely available. But for example, the British Neurotrauma Group have proposed a new classification system where you can go over many of the different details and aspects of the different type of conditions, because what we have understood is that also the outcome of these different type of conditions are not the same. And it's not the same to face a patient with a small epidural versus a patient with a huge epidural, or the outcome of a patient with an epidural versus a patient with a subdural. So there are all different type of conditions that have different impact at the secondary injury level that we need to understand more in profound. And we are entering into areas like the area of connectomics neurotrauma. We understand that the new type of imaging modality and interaction with network theory can allow us to go in more detail about the disconnection of the network in some specific categories of injuries. And this is also related to the rehabilitation process and the recovery process. We need to understand also that this technology is not widely available and is more based in areas that they are doing specific research on the topic, but it will be available in the near future. So let's give a space to move to the objective 2. So with that framework that we just discussed, we understand that we have a system challenge that is related to the context, conditions, environment, the level of knowledge of the healthcare people that is working within with these patients is really critical. But we also understand that the fundamentals aspects of the knowledge that we have from the pathology per se is also evolving and is moving to new concepts that if we want to really understand that, we need to go a little bit more deeply into the concepts from our regular perspective. So now move to what is already here, what we are already using to work with these patients. So we mentioned about the guidelines or consensus and protocols and algorithms that have been developed. So let's discuss some of these present trends, especially for diagnosis and decision-making for the management of these patients. So we have been mentioning the clinical evidence and the practice guidelines. We have here some of the more recognized ones, especially from the Brain Trauma Foundation. I just want to share here one example of the exercise that we do in Colombia with the Ministry of Health, supported either by the Brain Trauma Foundation and also by the Cochrane Collaboration Group. And we develop also our local guideline, very based on this already developed. But we all understand the difficulties in knowledge transferability and applicability of many of the recommendations from these evidence-based guidelines. Sometimes when you go over different regions of the world, many people do a really total different interpretation of the recommendation, and they didn't have like the level of expertise sometimes or the deeper knowledge about going basic concepts, like for example, the ICP threshold. This has been very discussed, and when the guidelines talk about a specific threshold, 22 millimeters of mercury, that didn't mention that this need to be a fixed number that we need to use always to starting or decreasing therapy. We understand that this is just part of what evidence shows, with some specific studies that sometimes are weak in the methodological aspects. So interacting with this type of documents is really important, and we still are not in the point where everybody interacts in the same way. And we need to remember that at the end, what we are doing, generating transferability of knowledge of these documents, is going to be reflected into the daily based practice management of these patients. So understanding that there are still many gaps in the evidence, the consensus of experts has been trying to fill those gaps. We have here two examples related to decompressive craniectomy and cranioplasty in trauma, where many experts around the world from different regions using the techniques often and frequently come together. And it has been really interesting because if you consider one of the last studies that were performed by the group of Cambridge related to acute subdural management, if you go over the results of the study, that is driven by a specific methodological science, and you go over the expert consensus, talking about how to manage a patient with an acute subdural according to the expert consensus, was really interesting how sometimes consensus can meet the evidence and the recommendation is exactly the result of the study. It's not always the case, but in some cases that happens. So that means that sometimes this consensus works and can be used sometimes filling these gaps. We have a recent consensus-based algorithm for management of recommendation for management TBI patients with polytrauma. We understand that many of the guidelines have been associated with isolated TBI patients, and sometimes, especially in LMICs, many of these patients arrive with polytrauma. So there are some sorts of recommendations, but most of them are based on resources that are not are only available for high-level settings and not worldwide transversally. But we also need to how to generate knowledge transferability for this type of recommendation. We have a new consensus dedicated to the management of TBI in absence of neurological surgery services. This is something that happens in many regions of the world. Some patients arrive to very rural centers or low-level facilities that do not have access to neurosurgery immediately. So there are some interesting recommendations here of how to interact with these patients. But it's also sometimes dedicated to resources that are not always worldwide available. We have the famous CREVIS protocol developed from especially a group of Latin American intensivists who works with Dr. Randy Chestnut for many years in the non-ICP versus ICP trials. And the most important aspect of this consensus is the possibility to understanding which conditions associated to the clinical exam and the CT findings can be associated with a possible high intracranial pressure patient, and also how to escalate and de-escalate therapy according to the clinical exam and the CT findings. So this is a tool that can be used worldwide in many regions that still manage patients only based on this criteria. We recently performed a survey in Latin America by the group of LAVIC, that is the Latin American Brain Injury Consortium. And in that specific survey, the answer was associated to at least 80% of the centers in Latin America still manage TBI patients only based on the CT and the clinical exam, not really based on any kind of neuromonitoring. So this is really interesting, but definitely show us how we are still in a very, very non-evolving process for managing these patients. CT and clinical imaging have been described as the pivot for managing these patients since the 60s and 70s, where the CT was developed. And if you go over many other conditions like brain tumors, vascular diseases, we have evolved a lot in neurosurgery. So the question is why we do not evolve at the same rhythm with TBI care. We have one of the civic consensus that is dedicated for guiding management of TBI patients with CT plus invasive ICP monitoring. We have here one of the posters that was developed with the Brain Trauma and Neuro Foundation for having in different languages worldwide, so it's widely available. And we have the second consensus where you integrate ICP plus invasive oxygen monitoring. And this is also very interesting for areas that have this resource, because it really shows how you need to move to personalized medicine, and not all the patients are the same. So the question is, if we are moving in this direction, we need to move in this direction, not only for areas that have all the resources, but definitely we need to find how to move also to personalized medicine in areas that do not have too much resources. From our group, we developed this series of protocols based on the bootstrap concept, that is moving from one protocol to other protocols according to the level of resources. So we are in the process now of studying this, the impact of this in a before and after implementation of the protocol study. Hopefully, we are going to have the result for next year. And this is based on if you are at pre-hospital level, in many regions of the world, you can have a heterogeneity of conditions where even you are in an ambulance that do not have equipment or do not have trained personnel to maybe services that have all the resources. So even for each one of those conditions, you can have some sort of recommendations that allow you to organize the care. And you can move from there to an emergency room that either can have CT or not CT available. And in that specific emergency room, you can be in areas that do not have too many resources or there is lack of training for the providers there, to areas that have all the resources and very high level of training with intermediate levels, like some areas that have some of the resources but not all of them. That means are the yellow blocks. And then you can move to areas that have neurosurgery or even non-surgical providers taking care of the surgical conditions of patients. And then you can move to a full ICU or to non-full ICU services like intermediate units or even patients that go to general wards in order to be managed post-operatively. So for each one of those, there is a specific protocol with some algorithms and recommendations. The algorithms show very easy that you can move, if you are in a very basic area with no resources, you just move over the red blocks recommendations. If you have some sort of other level of resources and training, you can move over the yellow ones. And if you have the full set of resources in high-income countries or something like that, you can move to the green one. So this is a system that we have been proposed, and now we are also doing a practical exercise with that for spinal cord injury. These are some of the examples. You have the article available, but also you go of the supplementary material where the specific protocols are described, and you can take them for knowledge transferability to any region of the world. So until now, which kind of documents we have, technical documents that allow us to improve the organization of care. We have all these series of different consensus protocols, the algorithms that are organized for some sort of specific conditions for managing these patients. So if we move from what we have now, what is missing? This has been the work that we have been doing with WHO for several years, is trying to understand a little bit the interaction of many of the providers in these regions. And what is missing has been recently described by some of the Lancet Neurology Commission reports, integrating the results of the track TBI and the center TBI studies, showing what is already there. Very critical aspects like the hospital care in LMICs is very suboptimal, but it's something that we need to focus on. There is a current lack of triaging specific conditions. There are sometimes not possibilities of going over personalized care when we are talking about triaging these patients. There is little evidence to inform treatment for specific populations like elderly patients. There is very poor access to rehabilitation, especially in LMICs. But also there are positive things like trauma care network have improved, but especially in high-income settings. There are good outcomes when you use this type of protocols that we just discussed. And there is high quality of acute and post-acute care that is correlated with improving outcome, but as has been mentioned before, especially in areas that have most of the resources. So we have been discussing many of these aspects, how to translate many of this knowledge that we already have to regions with limited resources. And it has been also possibilities to propose some different algorithms generating innovation with, for example, non-invasive devices that have been included in the human textbook for TBI care in resource challenge environments, specific indications for transfer. And we now understand from many of these new paradigms that we need to be more based not only on ICP or even monitoring or even brain oxygen monitoring, but also understanding the role of the compliance and the auto-regulation within these patients. And we can propose to have auto-regulation evaluation, even in areas that do not have too many resources. If we start using many of the devices that have been evolving over time, now we have a series of many different equipments that are not really expensive and are more portable, that are sometimes non-invasive, and you can try to move into understanding deeper what is happening inside to the school of patient, not only based on the CT, but also based on compliance evaluation and oxygen evaluation with this type of devices. So we have been publishing specific recommendations and examples of experiences in those topics. We have now systems that are allow us to detect intracranial bleeding in absence of CT, and some systems that allow us to understand compliance in absence of invasive monitoring systems. So there are already tools there that need to be integrated into these pathways of care. So in order to go over the final section, meeting objective 3, that is how to transition from present to future trends in personalized and precision approach, looking for impacting the outcome of patients in an organized care system. The best example that we have, as has been mentioned, are the track TBI and the center TBI studies, the multi-million dollars studies integrating many centers in two specific regions, one in Europe and the other one in North America, um, understanding actual practices and comparative generation evaluation of comparative effectiveness in these settings. And also, we have been trying to put into the lights the importance of the very specialized training in these matters and how we can interact in collaborations, North-South collaboration and high-income countries, LMICs collaborations for improving the technical education of the people that is going to be taking care of these patients. So as we have been mentioned, it will be important that during that type of training, we give skills to the people in order to develop the neurotrauma care system, as was mentioned many years ago by Dr. Lawrence Pitts. Pre-hospital care is part of this, and many of the neurosurgeons at some point need to be involved into the educational aspects of the developing of pre-hospital care. We have the famous EPIC study in Arizona showing that if you use guidelines at pre-hospital level involving the organized system of care, the outcome of the patient improves. All these studies that have been performed, the track TBI and the center TBI, have shown us a lot of important data in order to understand where are the pitfalls and where are the areas that we can improve. This talk about quality improvement that has been mentioned by WHO since many years ago. And the way to do this, even in LMICs, is to generate clinical registries. So the idea at some point will be to have a track TBI, center TBI, a study or project for Africa, for Southeast Asia, for Latin America. We have been very fortunate that we started this process some years ago, and we are now collecting data over the whole region. We have this project called Latino TBI, where we are integrating at least 8 or 10 centers from the region, putting data together. We have now more than 2,000 patients into the database. And the idea is to fulfill the same pathway that has been described by the center TBI and the TBI. The only difference is that we are working here with less than 10% of the money that regularly is used by these big studies. And also the importance of the specialized neurotrauma training programs. This is an example of our fellowship program that has been supported by the Cambridge Group and initially at some point by the Finnish Children's Hospital with Dr. Dave Adelson and Hutchinson. And it has been a very successful process, having residents from many regions of the world that can be exposed to managing TBI patients in so different conditions in high-income countries, in LMICs, in areas well-resourced, in areas with not too many resources, so they can understand in deep all these pathologies and physiological conditions that we have been described. And finally, we need to maintain CME programs integrating these concepts. It's not often that we can have access to a program of education that integrate many of these concepts that we have been discussing. So this is something that we are trying to achieve with the specific organizations. In this case, Global Neuro Foundation. We all know Global Neuro Foundation as an entity that is fully dedicated to neurotrauma education in different aspects worldwide. I just want to highlight some of the recent programs that we have been developed. There is an online certificate program for nurses that want to be more focused on neurotrauma care. We have an online diploma that has been very successful for neurotrauma care, mostly taken by neurosurgeons, young neurosurgeons, and also young intensivists. This is supported by the Neurotraumatology Committee of the World Federation and also the Young Neurosurgical Forum. And we have many courses taking courses with more advanced skills, even practical stations with many of these systems that we have been mentioned, either invasively or non-invasive systems, surgical techniques that we are regularly doing in areas with lot of resources, but also in areas with less resources. And this is an example of one of the courses that is scheduled for Cape Town during the World Cup. So this is all that I want to share. These are some pictures of our center in Cali, where we integrate the management from low-level facilities to the higher-level facilities, our research center, and the Hospital Universitario del Valle and Valle Salud, a clinical network where we are trying to bring all these concepts for the persons that are in training with us. So thank you so much.
Thank you so much.
Thank you.
Simon.
Thank you very much, Professor. Thank you very much for that very enlightening presentation. We've got a few questions from the participants. However, I would like to just go through a brief summary of everything that you've said. You've talked about the current landscape of neurotrauma care and management globally. You've talked about the technological advancements that the entire world is experiencing right now, more so in the developed world. You've also talked about global disparities, how do economic and resource disparities impact the quality of neurotrauma care in different parts of the world. Are there initiatives or strategies in place to address global disparities in neurotrauma management? You've talked about preventive measures, multidisciplinary approaches, patient-centric care, research and innovation, education and training, policy and advocacy, and future challenges and opportunities. I believe many participants would have one or two questions for you. For right now, I'll begin with a question from Mr. Henok from Ethiopia. He says, I have noticed a high rate of hemorrhage progression in hypoxic patients. Do you recommend routine oxygen support for intraparenchymal traumatic hemorrhage, even if these patients are not hypoxic? Dr. Rubiano?
Yeah,
yes,
thank you. I think this is a very interesting question, and the whole point comes if you are monitoring brain oxygenation or not. Because we understand that sometimes we focus on hypoxic concepts only for the systemic approach, but when you are monitoring hypoxia at the brain stage, sometimes you have not hypoxia at systemic level, but you have that at the brain level. So I think all depends of if you are incapable of evaluating brain hypoxia. But if you go over many of the fundamentals about general management of TBI patients, in general, oxygen is recommended. But we understand that oxygen sometimes is lacking in many regions and is very like a luxury medication sometimes in some regions. So you need to always take into consideration which patients need the most that. Something that needs to be explored, as we have been supporting the idea of using at least NIRS technology to understand frontal lobe brain oxygenation in areas that do not have too many resources. And if you have the possibility to have more invasive systems like even jugular saturation of brain tissue oxygenation, you can move to that type of protocol.
You're muted, Simon. Simon, the mute.
Yes, so sorry about that. Yeah, Hedon from Ethiopia still was asking another question. He said, is there a scoring system or guide that can predict the risk of deterioration for patients with moderate GCS and traumatic hemorrhage, specifically frontal and temporal lobe hemorrhage with volumes less than 20 cc's? He says the reason he is asking this question is that conservative management with strict follow-up in possibly ICU and ICP monitoring is recommended in textbooks for this group of patients. However, in countries like Ethiopia, ICU as well as ICP monitoring is inadequate, and the pathology has a tendency of fast deterioration, which requires fast surgical response. That is difficult in low-income countries where resources are limited and bureaucracy is high. I think what he's actually saying is that in the low and middle income countries, we kind of do surgeries faster than in the developed world because of the lack of monitoring equipment and ICU space and things like that. Maybe you could have a comment on that as well.
Yeah, no, totally. I think this is a problem that we recognize in many regions, the lack of resources to understanding a better what is happening. But now we have new technologies like, for example, non-invasive systems. I just mentioned the ultrasound of the optic nerve that can allow us to understand a little bit what is happening inside the skull. So we can identify not only based on the CT image, but also in actual trends of the patients. If this is associated with possible high risk of deterioration for high ICP, saying devices like the pupillometry, the digital pupillometry that can interact. We just recently have, 2 weeks ago, we have the global consensus for non-invasive systems for ICP monitoring. We are going to have soon the final draft of that meeting that I think will be very important for areas that do not have too many resources in order to start working with this type of system for define early surgical management. That is the thing that we can bring the most easy in this type of region.
Thank you very much. I'll go on to another question and another comment from Dr. Ignatius Esene. He says, excellent presentation, Dr. Rubiano. And he's asking, how is pre-hospital care organized in your country?
Thank you to Ignatius. I think as pre-hospital care has been one of the key aspects that has been mentioned in the Lancet Commission report and also from many of the different studies. In Colombia, is not different for many other regions in the Latin region that is pretty heterogeneous, you know. So there are regions that have really well-established systems, like in the main capital, but if you go over more smaller cities or even rural areas, there is nothing there. So what we need to work is trying to promote this at a political level in order to generate public policy for having a specific base care for all the people, not only, you know, in areas that have most of the resources. So now we have been involved in a couple of projects where there are new technologies that can be used, especially activating system, for example, by cell phones in areas that do not have these huge call centers that regularly responds for emergency care. So if you don't have an institution that have a 3-digit number, maybe that can be replaced by a very fast application for cell phones that can generate some degree of integration of the activation of the system. So we are working now in some projects related to that, and hopefully we can have important data soon that we can share with the people that is interested in this topic.
Oh, thank you very much for that answer. There is another question from Uganda. It's Dr. Ehanga. He says, thank you, Professor Rubiano, for this very informative presentation. And he says, what would be the impact on the management of the categorization of TBI in primary and secondary TBI? The impact of management of the categorization of TBI.
Okay, thank you for the question. I think the idea is if we move to personalized medicine, based on many of the discussion that we just had, definitely we can understand that there are interventions that need to be done for the primary injuries, but if we really understand in the more severe cases, we need to focus also in the secondary injuries and how we understand that. For that, that means that we need to move to a level where we understand what is the autoregulation of the patient, what is the compliance status of the patient, that we regularly imagine looking for a CT, but don't really measure. And we need to move to a point that we are actively measuring what is happening during this process. And that there are already tools like the transcranial Doppler, for example, that can be used in order to evaluate autoregulation and many other aspects that, as we have been mentioned, can be considered if you have the knowledge and training for doing that. That's why I want to highlight that it's really important that we act as or another subspecialty in neurosurgery, and as we prepare better people for working on a specific neuro-oncology process or neurovascular process, we need to really train people to work into neurotrauma, and that will be the way to move in areas that have a lot of patients.
Thank you very much. That's a great answer. There is another question from Ethiopia, again from Jose Sanguino. He says, thanks for the beautiful presentation. My question is the role of prophylactic frontal decompression for frontal contusions.
Okay, the prophylactic decompression, I think, can be still used in areas that do not have too many resources. We understand that if we don't have too much resources to understanding what is happening inside the school, maybe being more aggressive surgically is an option, because we don't have the tools to detect early deterioration of these patients. So it is better move faster other than wait for having a bad prognosis in these patients. So what we have been understanding now is that as much tools we have, we avoid the compressions that are not required. So that means that not always when we have some abnormality in the CT, it will require a decompression. But what we need are the skills and tools to use these new devices, many of them that are non-invasive ones, in order to filter better which patients are going to require early surgery. So I think we are in that transition process. So that's why exactly I mentioned the level of interaction that we have with the documents that have been produced, either at the guideline level or either at the consensus level, is that if we move with the document in many regions of the world, they can have different interpretations. And what we need to go is over a very based on the actual knowledge level of interpretation that can be beneficial for the patients. Because we understand that if we decompress many patients, decompression of many patients will take to complications of the surgery per se. There are most complications associated in patients that have decompressions. But if you move to a more conservative approach, you are going to require late surgeries in patients that are going to have poorer outcomes because we take the decision very late for surgery. So we need to have a balance between both. And I think at this moment it's really interesting because the tools that are going to take us into having better balance for that are many of these new tools that we just described, either invasively or non-invasively for understanding compliance, autoregulation, and oxygenation.
Andres, could I ask a question, if I could? You've talked so much about networks and the global aspects of trauma. It's very impressed. I'm very impressed at the pre-hospital setting, how we must cooperate with government and maybe even military to transport patients or organize care. Can you just comment on how we are not alone in this, but work in a society together?
Yeah, totally, Professor. I think what you mentioned is really important, is that we have sometimes many of the resources there, but they are not integrated. And what happens is that if we go over military management, we all know that sometimes in many regions of the world, There are some sort of organization for military emergency care, but this is not sometimes integrated to the civilian care. And what we need is to bring all these experiences together in order to bring this to the general population. What happened, that what you mentioned happens, for example, in Colombia. In Colombia, sometimes we have military helicopters to taking care of patients in very specific bad conditions sometimes, but it's not the usual case, you know. These helicopters are not integrated to the regular civilian care. So we have the tools there, but are not regularly used because we have not integrated this into the civilian system. So definitely that will be an important point to start the discussion, and that requires participation of the people that is involved in the care, in this case, the neurosurgeons. Sometimes we speak with many neurosurgeons in many regions, and they say, oh, no, I am not going to speak with the pre-hospital providers because, you know, I am the neurosurgeon. But the point is, this is how the work starts. And sometimes you are the best qualified people to teach the pre-hospital providers how to do things and to integrate your voice into the organization of the system.
It's wonderful because we have a position of influence we should use positively. Simon, could you wrap up our discussion today, perhaps with some summary statements, if you would?
Oh, yes, thank you very much. There are a lot more questions, but I believe Dr. Rubiano will be answering those on the YouTube channel that this presentation is going to be posted onto. It's going to be posted onto the FIENS YouTube channel. There are so many questions I see coming in from South Africa. Jennifer from South Africa, Dr. Harvey from Uganda, and many more. But because of the time, I think we'll have to stop here. Thank you very much, Dr. Rubiano. This has been very informative, and we look forward to having more of these presentations. Dr. Dempsey, thank you very much as well. We've been very privileged to have all these visiting virtual professors happening on this FIENS link. And I must say, on behalf of all the people who attended today, that we are grateful for the initiative and for the dedication. Thank you very much, and have a great day.
An excellent job, Simon. Thank you so very much. Andres, thank you for this wonderful participation, and all the audience, we thank you. We will try to address in the questions we see in the chat on our website. Thank you so much.